Our final speaker today, we got another native New Orleanian coming up to the podium, Dr. Kyle Rose. He's an accomplished pole vaulter, which is a fact that I just recently found out. He lettered for 4 years at a small school up the road called Louisiana State University. He then stayed on at LSU, where he earned his medical degree. And then he went up to the Mayo Clinic in Arizona for his urology training and did urologic oncology training at the Lee Moffitt Cancer Center in Tampa, Florida. There, he was published extensively in a variety of GU topics, but really developed a keen interest in the genomics of bladder cancer. And we were absolutely thrilled at Ochsner whenever we were able to recruit him back to New Orleans about a year and a half ago or so. To really help build up the research portfolio that we have here at Ochsner. He's also quickly become a real favorite clinical educator for both the urology and the oncology house staff. So very thrilled to have Dr. Rose come up here and give us a talk.
Good afternoon, everybody. This is a position I never wanted to be in for a couple reasons. One, I'm the only thing standing between us and cocktail hour, and I'm just as upset about that as y'all are. Believe me, nobody in this room hates the sound of my voice more than me. Okay, while I'm loading this up, I might as well drop a couple jokes. So, pole vaulter, as it turns out, is also slang for GU surgeon. If you guys didn't know that. Dr. Lopes is not here. She's one of our oncologists that works closely with Dr. Halbert and I, just while this is loading. We have something called Stupid Questions Thursdays, where she comes to my office and I ask her stupid questions that I'm too afraid to ask in public, and she does the same. And it's one of those things like we're so far down the rabbit hole now, we don't want to say it out loud, and someone's going to be like, dude, how did you get this far? Sorry, this is still opening. But with that in mind, when I created this talk about circulating tumor DNA, cell-free DNA, I really want this to be explained at a level that I would explain it to my patients and to my family, and not because I understand it beyond that, but because that's the level I had to learn it at. So this is still loading up. Give me 1 second. All right, pump the brakes. Okay, here we go. Cocktail time is coming. Okay, so this is my only financial disclosure from 2021 that I no longer have. And just for the sake of transparency, here's where all my finances currently go to the bloodsuckers there. So we're going to be talking about cell-free DNA today. And it's very specific, or very important to specify what exactly that entails. There's a lot of biomarkers out there that contain some sort of tumor genomics or some sort of biomarker. And so it's very important that we clarify that cell-free DNA is an extracellular nucleic acid, and also what's most important is it comes from the actual tumor cell. And because if we were to measure blood or urine from anyone in the audience, we're going to have a certain amount of cell-free DNA. Most of that is from our white blood cells, not from tumors expressed in our body. So that's important to keep in mind. And again, this is not circulating tumor cells or IHC markers. And the beauty of these assays is it allows us to look at tumor mutations, to look at tumor fraction, tumor mutational burden. There are several ways that we can analyze this data depending on the primary tumor source. And again, cell-free as a liquid biopsy is found either in circulating fluid like blood, such as serum or plasma, or excreted directly into the urine. And again, just to harp that the rules for this have not yet been written. But for the purposes of this talk, circulating tumor DNA is going to be any tumor DNA that is detected in the blood, such as the plasma or serum, and urinary tumor DNA is shed directly into the GU tract. And so I'm going to apologize for this, but this is why I had to update my slides. It's because I had to do some homework last night, and I'll start with a quote from my father who said, "Sometimes it's better to ask for forgiveness later than permission now." So I'm going to apologize for this example, but this is how I like to think of these things and explain this to my family. All right, so cell-free DNA is very much like a song with lyrics, okay? We're going to assume that the primary tumor is an artist and their song, and we're going to try to match the circulating lyrics within the body or the circulating tumor DNA in the body and identify what the primary song or artist is. And that can be the case if you're into Black Keys, Taylor Swift, or Wheezy. So in a tumor naive approach, we don't know what the primary tumor sequencing is. And so we're gonna give somebody song lyrics, they're spaced out, they're all flipped backwards, and we're gonna try to match it to a known song by a known artist, okay? And assume that a primary tumor is a true positive. So this was me last night on ChatGPT, and I said, give me a song where I lost my girlfriend, I lost my job, and I lost my truck. And that's pretty much, damn near every country song ever made. And this is only the first 25 because I had to tell it to please stop, okay? Similar scenario, what if we ask it to give us a hip hop song? So a hip hop song written to the other gender, and we'll just say something like it's about butts. Again, this could be anything. It's not very specific, but very sensitive. And so you can see how many options are spat out. And I'm glad the room is very far, so you don't see all of them. There's no curse words. I looked. Now, in contrast to that, if we use a tumor-informed approach, okay, we know what the primary artist is, and so the words we're looking for are going to be more narrowed. And so, for instance, if we were to ask that question about a hip-hop song written about butts, if instead of asking that very broad question, we say, let's find a song with the words very clearly, I like big butts and I cannot lie. That is one song that we all know very well, right? And so that's a much more narrow question. On the same side, what if we know the author, what if we know the artist, and we know what the words are, but we're still trying to narrow it down. So for instance, if you know the primary artist is the Red Hot Chili Peppers, the lyrics contain California. Again, that could be 12 songs, 5 different albums, but if it's Californication, then we know it's 1999, the 6th track, okay? And before anyone jumps for me, I know that's not the album cover, that's from Blood Sugar, but just for an example, okay? And so cell-free DNA or circulating tumor DNA is not just a binary yes-no answer. Did we find the cell-free DNA in the blood or the urine? But also what percentage of the total cell-free DNA in a given sample is derived from the tumor? And so tumor fraction comes into play. Using the same lame example, I'm sorry, but if we took a given textbook, how much of that textbook has the words from the song in it that we can then go out and find? And what we'll find is, honestly, the amount of tumor DNA circulating through our bloods is very often less than 1%, less than 0.1%. And this is very important when we consider all aspects of urothelial carcinoma. I will focus today mostly on muscle-invasive bladder cancer. We will also touch, just for reference, on upper tract carcinoma and non-muscle invasive bladder cancer. So again, cell-free DNA, we're looking at genomic material outside in the periphery or shed through the GU tract, and so we need to know what the primary tumor genomic landscape is. So we need some background. This is Tallinn, Estonia, where my wife is from, where we got wed. Beautiful place if you haven't been. But again, we are going to be covering non-muscle invasive, muscle invasive, and upper tract carcinoma. It's important to keep in mind that non-muscle invasive and muscle invasive are two very heterogeneous cohorts that are treated very differently. In non-muscle invasive bladder cancer, we try to do everything we can to spare the bladder and do localized treatments, such as TURBT or BCG. In muscle invasive bladder cancer, that is obviously invasive, as the name implies. It has a propensity to spread and to metastasize to the lymph nodes and distant organs, and so it's treated very differently. And for example, non-muscle invasive bladder cancer is typically 75% of all new bladder cancer diagnoses. We try again to preserve the bladder as much as possible, but it's a very heterogeneous cohort because some of these patients can go on to progress, some of these patients can recur, and we can use cell-free assays to monitor the response to therapy. In terms of their genomic landscape, these tumors tend to have a higher proportion of TERT mutations. Low-grade tumors tend to be amplify FGFR more commonly, whereas high-grade can demonstrate TP53 alterations. In general, and what we'll see is that with increasing stage, there's a higher, with the increasing stage of all bladder cancers, there's a higher occurrence of cell cycle regulating mutations. So muscle-invasive bladder cancer, the reason we're here, the reason we wanted to give this talk, this is very aggressive. It's important to manage this by the textbook, and typically the treatment needs multiple teams on board for several different types of treatment. This patient on the right, I don't know if Brian has seen this before, but this is a patient that Brian and I shared together. She had a right lateral wall bladder tumor, and at the time of this picture, she also had a right pelvic lymph node. Thanks to Dr. Halbert, that lymph node did not have cancer in it at the time of her bladder excision. But I cite this paper to our patients every single time I see a new patient with muscle-invasive bladder cancer. This is a Swedish study, and it's very sobering data. And I don't present this to scare patients, but for muscle-invasive bladder cancer, treatment is aggressive. And I want them to understand why we're doing the things we're doing. Why are we offering them a truly life-altering surgery or toxic chemotherapy if we don't know what the alternative is? Well, the alternative is that if you don't treat muscle-invasive bladder cancer, your 5-year survival is 5%. If you don't treat muscle-invasive bladder cancer, the median survival is 18 months. And so this was a study out of Sweden, obviously a small cohort, but this is a tougher study to do. Typically, this is observational data, but important for me to tell the patients, this is why when you have muscle-invasive bladder cancer, I'm gonna send you to Dr. Halbert, who's gonna give you toxic chemotherapy. We're gonna do a very extensive surgery with a high complication rate, but this is why, because the alternative here is a high risk of death. And it's funny how this works out. When you're making slides for this presentation, I'm thinking to myself, what are areas that are really important to identify in general for muscle-invasive bladder cancer? And as I make this list, I also realize that every single one of these topics is what circulating tumor DNA and cell-free DNA can help answer. So that is including helping us to identify patients who need systemic therapy prior to surgery, patients who do not respond to systemic therapy, patients who have completed a resection, we consider them to be T0, but they're at a high risk for that cancer coming back. And then lastly, patients who recur or persist after cystectomy. And humbly, I have to admit, through all these pieces where I say these are the areas that would be so helpful for me as a surgeon to identify, the role there is not for me to operate more. The role there is for me to turn to someone like Dr. Halbert and put those patients on a systemic therapy or change the agent that they are on. So truthfully, the take-home message in all of these except one is who can get systemic therapy. Again, for the background for muscle-invasive bladder cancer, these are very aggressive. TP53 is commonly mutated. There have been multiple genomic studies looking at clustering of DNA in this tumor type. Unfortunately, those haven't really panned out. They haven't really changed how we treat them. Dr. Lerner and TCGA had a landmark study, and there have been multiple prospective prognostic studies, but none that have really changed how we categorize and treat patients differently. I'll touch very briefly on upper tract cancer, just to demonstrate that when this is aggressive, we manage it similarly to muscle-invasive bladder cancer, where patients get preoperative chemotherapy followed by extirpative surgery. So if anyone does want to read up on more of this, we had a review article out in NRU last year, which had looked at circulating tumor cells for upper tract, non-muscle-invasive, and muscle-invasive bladder cancer, as well as from the urine. And what I really want to outline is what the roles are between urinary tumor DNA and circulating tumor DNA found in the blood. Urinary tumor DNA is very frequently found in all types of bladder cancer. It is a good binary question, yes, no, is there tumor still there? And we can find tumor DNA in the urine in up to 71 to 95% of patients with any type of bladder cancer. The higher or more aggressive types of cancer, those typically have a higher rate of positive ctDNA, but as we'll see with ctDNA being present, urinary tumor DNA is almost always positive. This is a very interesting study that we did at Moffitt when I was a fellow, and this was in NMIBC, but this was really to outline what is the role for urinary tumor DNA to detect if there's any tumor present after TURBT. So for intermediate risk non-muscle-invasive bladder cancer, the standard of care after a TURBT, even if we think we scraped everything out, is to go back to the OR and do it again. The reason for that is that 25% of patients still have tumor there, even if we couldn't see it after the completion of our last TURBT. And in those patients that have tumor still, 30% of them are upstage to muscle invasion. So it's critical. It's very important in standard of care. But that also means that we are overtreating 75% of patients. And depending on who the patient is, what the patient population is, that's 75% of people that are undergoing another general anesthetic, another risk of TURBT, and then the financial toxicity that walks hand in hand with that. And so we asked this question, could we use the urine to identify what patients have tumor left over in the bladder after a standard of care TURBT? And using tumor fraction, again, that's the proportion of tumor DNA found in the urine compared to total cell-free DNA found in the urine. Can we identify the patients with tumor left over? And we found a specificity of 100% and a sensitivity of 75%. Again, just to hammer home how common UTDNA is in patients with non-muscle invasive bladder cancer, we can detect UTDNA, depending on the study, in 91% of patients who ultimately have a reoccurrence of their bladder cancer. And most importantly is that the tumor DNA detected in the urine will precede detection by white light cystoscopy by our own eyes in up to 92%. And what's even more controversial, the only urinary marker that we have right now that's considered standard of care is a urine cytology. And excuse the phrase, but urine cytology is a piss poor study, okay? It's not very accurate. And when in this study we considered all of the patients that cytology missed, this assay was able to capture 100% of them. Okay, so back to the main event. Muscle-invasive bladder cancer. Again, highly aggressive, multimodal treatment. When we do surgery on these patients, we typically take the bladder out, including the prostate in a man. On the top right here, we take out the lymph nodes depending on the area or what's involved, and then we have to figure out what to do with the GU tract. And sometimes we create an external pouch called a ileal conduit. Sometimes we create a new bladder that's either catheterizable or one that goes down and drains the way we were born. So again, ctDNA in this role, circulating tumor assays are better to identify which patients have aggressive cancer, whereas that in the urine is to tell us yes or no, is their cancer still there? This was, again, a study we did out of Moffitt during my fellowship, where we looked at 22 patients with muscle-invasive bladder cancer. We analyzed their urine and blood prior to cystectomy and found a 44% concordance rate between the plasma and urine samples. There was a positive correlation with pathologic T-stage between the plasma tumor fraction and the tumor fraction in the urine. We did find a higher mean urine tumor fraction in patients who had CIS or non-muscle invasive bladder cancer at the time of their procedure. This was really the landmark study done in 2017 by a Danish group that really got ctDNA on the map and held tremendous promise. There are really 3 time points of interest here. The first one that we will talk about is before surgery. And so those are patients who get a ctDNA measured based on the primary tumor type before chemotherapy and before cystectomy. Patients who had a detectable ctDNA prior to treatment had a substantially poorer survival with a hazard ratio of 29.1. I mean, wow. This was really groundbreaking stuff, and this was only a third of the findings in this study. And so that's looking at the entire group of patients. Now, one of the issues with any sort of clinical trial that we do, there's some inherent bias where we have a population of 100 people, 200 people, 1,000 people. On some level, we consider each patient to be the same person, right? That is really the intrinsic bias for a randomized control trial, is how we interpret that. The beauty of this study was actually broke it down to on a single patient or a individual layer. Where we can monitor patients' ctDNA while they're on treatment. So the patient in the top left here, patient had circulating tumor DNA that was detected. They had neoadjuvant chemotherapy, dropped down to 0. They had cystectomy, and then their ctDNA went back up, put them on chemotherapy, and starts to come back down. And so there are implications here that we can monitor patients while they are on treatment to identify patients responding well or patients who are not responding well that need to go on to surgery. And then again, some patients who are ctDNA positive, they undergo surgery and their ctDNA stage 0 for long term, and then we can use it to watch them long term as well to identify if any tumor recurrence occurs. The third time point is after cystectomy. Any patient who was positive for ctDNA after cystectomy had a poor outcome. And this is really cool. ctDNA recurrence produced a lead time over cross-sectional imaging of up to 91 to 101 days. So we can identify patients a full 3 to 4 months prior to a CT scan that their cancer may be coming back. Why is that important? Because then we can identify patients who need adjuvant therapy or should be placed on early salvage therapy. These are some similar trials that had looked at ctDNA after neoadjuvant chemotherapy, after the second cycle specifically. And again, on the patient level, this was able to monitor the change in the tumor type while on therapy. And so you can imagine if a tumor cell contains, let's just say for a round number, 100 cells, or a tumor contains 100 cells, we give them cisplatin. All the cisplatin susceptible cells die off, and then we're left over with cisplatin resistant cells. We can identify those cells in real time, identify if we need to adjust their treatment at all or if we need to move on to surgery. Similarly, this is from the same group out of Denmark, looking at the recurrence rate after cystectomy. In patients who are ctDNA positive, 89% of those patients end up having a tumor recurrence and needed to either go on hospice or go on additional therapy. When ctDNA was positive in these patients after cystectomy, urinary tumor DNA was detected in 100% of patients. So again, tremendous promise. Just for brevity's sake, I want to touch on upper tract cancer. One of the issues that we are very poor at in our profession is staging upper tract cancer. There's also a significant stage discordance in muscle-invasive bladder cancer, which is why I included this. But in upper tract carcinoma, it's very well known that we significantly understage these patients. So we use circulating tumor DNA, again, out of Moffitt, prior to patients who underwent a NEFU. Any patient that had ctDNA positivity was most likely to have T2 or non-organ confined cancer at the time of their final pathology. And the presence of positive circulating tumor DNA preoperatively was strongly prognostic for progression-free survival. Okay, IMvigor010. This is a clinical study on muscle-invasive or advanced bladder cancer patients who were status post-cystectomy. So these are patients that I would take to the OR. I get their pathology back. They have advanced like T2, T3, T4 cancer of the bladder, or they have nodes positive. I call up Dr. Halbert and I say, hey, I'm really worried about this person. What can we give them? So this is being given in the adjuvant setting with no known evidence of METs. When we administered everybody either a TIZO or observation, we did not identify a difference in outcomes, okay? So this was not a positive trial for us. However, what if we ask the question, what if we stratify those patients by ctDNA instead? And this is, again, groundbreaking. We had a negative trial that now has signal for patients who are ctDNA positive. And you can see at the bottom left here, patients who are ctDNA positive that received a TIZO in the blue arm had better outcomes and better survival than patients who were placed on observation. In contrast, patients who were ctDNA negative did not see a benefit in this adjuvant arm. And just read out about a month and a half ago was the long-term data associated with this, showing that difference in survival on ctDNA positive patients is again preserved long-term. This is again part of the second follow-up study to that, showing that not only is it a binary yes-no answer where they ctDNA positive or not, and how do we treat them, but we can monitor their ctDNA while they're on therapy to see how much of it they clear. And so in the top green line here, these are patients that cleared their ctDNA completely, meaning that we couldn't identify tumor in their body, we couldn't identify tumor fractured DNA strands in their blood either, compared to patients who had a poor clearance or a suboptimal clearance had worse outcomes. And again, these are patients who were ctDNA positive at the time of surgery. After surgery. Most recently published this past month, this was from Dr. Gupta in Cleveland Clinic. This was again using tumor fraction, which is the percentage of tumor cell-free DNA compared to your total body cell-free DNA found in a sample. This had looked at patients with advanced carcinoma, but again, analyzing tumor fraction, they found that when that tumor fraction was significantly higher, so greater than 1%, that was associated with a poor prognosis, a reduced progression-free survival, and a trend towards a decreased overall survival as well. Here are some of the curves showing that patients who were ctDNA high had a worse outcome compared to patients that were ctDNA tumor fraction low. So, in conclusion, all that to say, there is tremendous promise for cell-free assays in this space. It can help us identify tumors, watch the response to therapy or on treatment, identify patients that have tumor left over even after standard of care treatments, and to identify patients long-term who need additional therapy, and to monitor those who relapse early prior to conventional studies. There are multiple problems to be addressed. Most of these are real world, and that may be why in the GU space this has not worked its way into the guidelines yet. I sincerely hope I do. I hope it does, but if anyone's going to ask questions about how many patients do you use this on, well, it's not in our guidelines yet, and so the rules have not been etched in stone yet either. And so it's important for us to get prospective information, work on turning around the test results from this very quickly, and then to ultimately decide on a tumor-informed approach versus one in which we do not sequence the primary tumor. With that being said, I wanted to thank everybody for allowing me to speak here. Thank you for tolerating the corny jokes, and I'll see y'all at the bar.
Thank you, Dr. Rose. You guys will see him at the bar, but you're also going to see him in a couple minutes right now answering questions. For those of you who came to this urology session expecting urine jokes, you're in luck. I screwed it up. I even screwed up the delivery, too. No, seriously, Kyle, I'd seen your slides beforehand, and I knew that you wanted to get those updated ones in before. I did not know why. I was like, I don't know, he like misspelled something. Like, what's the big deal? I get it now. So we'll open up the floor for questions. We do have a microphone up here at front for those of you who want to come up and ask some questions. I think we've got a great panel here. We can have a good discussion. While I'm waiting for people to come up, I'll just go ahead and start with one question. I'll bring this to the panel. I know, Kyle, you were just talking about the IMvigor data, which was a negative trial. We do have 2 positive trials looking at adjuvant pembrolizumab and adjuvant nivolumab in disease-free survival for adjuvant treatment in bladder cancer. We don't have overall survival for those treatments yet. In practice right now, I think that's considered standard of care. It's certainly what I do, but should we be testing ctDNA in these patients and offering based off of that?
Thank you, Brian. Should we be testing ctDNA? I believe so. I think we should have that data. I think the problem is that from a medical legal standpoint, I don't know that we have great guidance on what to do with it. And I contrast that to our colon cancer patients who do have some of that guidance, and there's patients that we take care of jointly with them, and they have much stronger guidelines, it seems. I think it's an interesting point. I think that day is coming, but I don't know that we can act on it yet. I do think it'll help us to better inform the patients so that they can make an informed choice.
Just 2 follow-ups on that. I've had 2 recent patients I can think of where I was really thinking about these data. One in whom technically the adjuvant trials did not apply, PT1, but with aggressive histology, micropapillary features. And so the question was, should we sort of expand the edge of those eligibility and answer a question that couldn't be answered from the RCTs? And so that was a situation, essentially we were trying to talk ourselves out of giving adjuvant therapy in a situation that was a little bit outside the box. So we did use it there. It was negative, and that made us feel a little bit more confident, and it was reimbursed. importantly. And the second scenario I had recently was a woman who unfortunately got dose-dense MVAC and still had YPT3B N2 disease, really nasty stuff. And that was a scenario where I actually said we should not get ctDNA because she's so high risk that I wouldn't believe it if it were negative. I would be very worried about it converting very quickly. And the last thing I would say is that there's actually an alliance trial that's being led by Matt Gulski. Oh, do you want to talk about it?
No, I was going to say, but you go for it.
Sounds good. It's basically testing an escalation-de-escalation strategy based off of ctDNA.
Yeah, that's the modern trial. I am hoping that we can open that up soon. I think it's in feasibility right now. I'm going to stand up here because I'm hidden behind the microphone. I'm hidden behind the podium. In the absence of anybody coming up to the podium, come on, you can shout stuff out too, but I can keep going for questions for a while if you want me to. I will pose a question to Dr. Crane then. Dr. Crane, two questions actually. Number one, I think you were showing a lot of data from these old randomized trials looking at radical treatment for prostate cancer and localized disease. Really asking the question, are we improving mortality for patients? These are old trials. How much more are you concerned about the newer era where we have more effective metastatic treatment? And then the second question I was going to ask is the use of MR imaging for staging prostate cancer. Are you pretty much assuming that all men that have extracapsular extension on their MRI are at high risk and should be treated as such?
So to answer the first one quickly, yes. If you have radiographic disease outside of the prostate, you really should be treated as a clinical T3. I am somebody who has stopped doing DREs in my daily practice. I think it prevents more men from coming into my clinic than it misses cancers, especially in the MRI era. And so I'd rather cast a wider net for men who aren't afraid to walk into my clinic because they don't want to get a DRE. So I use MR in that setting, which is a very expensive tool, but that's what I do. Going back to where you are before, I think that poses a really important question because I like to consider myself young, but it's almost been 10 years since I graduated from residency. And during those 10 years, we've come out with at least 8, if not 10 new approved prostate cancer medications. When I started trying, we had docetaxel and ADT, and that was it. And now here we are 15 years later, and there's a lot of opportunities. And when you went back to look at that initial SPCG trial, the mean overall survival improvement was less than 3 years. And you're starting to see that number come to fruition, particularly in the earlier disease states. I am putting a lot more patients with 3+4 disease on active surveillance in my clinical practice because I do think there's a lot of ability to salvage these patients when they get older or if their disease were to progress, because I think our treatments are just that much better.
Excellent, thank you.
I guess one follow-up point on that on the PROTECT data is that even on the active monitoring group, about half of those patients ended up getting deferred therapy, right? So that's really a question also, is sort of who actually needs to come off of active monitoring, active surveillance, and knowing that it's not a trial of doing nothing in one arm.
Excellent. Looks like we have a question at the microphone.
Hi, everyone. Is this on? I'm not sure.
It doesn't sound like it.
We can hear it. Projecting, so that's why I wasn't going to stay at my seat. But thank you all. Very fascinating talks. I was really struck by that survey about the quality of life for these patients. And I guess it kind of got me thinking, are the current surveys that we do in our clinical trials sufficient? Or do we need to think about really revamping these? And if so, do you have any ideas?
So as somebody who grew up in the deep urology cancer world, this is going into soft science, it feels like to me, right? And it's tough to go out at meetings and be like, oh, well, this is survey-based data. But I think we really do need to change what we're doing, right? Because like I said, one of the things that we looked at was the overall impact on overall quality of life, right? And there actually wasn't a difference between those 3 groups when you randomized them out. And if there's not a difference between these groups, maybe we're not asking the right questions. One of the things that we've been focused on in my practice, the VA, is actually, and where we've gotten funding recently, has been looking not specifically at that, but really looking at the interaction between the provider and the patient in terms of trust. I don't look like most of my patients. Most of my patients didn't grow up with a physician father, with a 2-household income in New Orleans, and went to private school. That's just not who most of my patients are. And I think that there's a big issue with how I present my information to patients and how they perceive that. There's a lot of really interesting work coming out at NYU looking at sort of some of the promotional work and how if patients look like the person who's giving them information, they probably adapt to that and they receive that information a lot better. What we've seen, and this is from both survey and then formal interview data that's been submitted, not published yet, is that many of our patients have a lot of, because we're really focused on the African American subpopulation in New Orleans and South Louisiana, have a very heavy distrust of medical systems. Which we went back and looked at the data, and you can parse it out, and it's not physician that they don't trust. Most people say, listen, I sit down with my doctor, and when I sit down with my doctor, I trust my doctor. I think my doctor will help me make the right decisions. But then if you ask them the same question, what about and this is at the VA, right, which is a very well documented, heavily trusted system. That's one of their metrics. Patients routinely say, I don't believe the medical center. I think they will hide mistakes. And that is very interesting to see that there's that dichotomy between that. So, yeah, a long answer to your question is I don't think our surveys are full, and I certainly don't think a survey from 12 years ago in Australia is fully representative of what we have currently in our system.
I 100% agree. I think that data that you showed showing, stable mental health amongst patients is not representative of the data you showed from the Reddit subgroup, which is also probably not the most representative sample, but it is certainly a real group of people, and they are out there on the internet, and they have real problems that we are giving them. On the heels of that, kind of staying on the theme of what are we doing to harm patients? I have 2 urologists up here. We talked a lot about intermediate risk prostate cancer. We have good non-metastatic STAMPEDE data looking at intensified hormonal therapy with radiation therapy. What is the current role of prostatectomy in high risk and node positive prostate cancer?
Great. I would say it was previously controversial. We have an ongoing clinical trial out of MD Anderson, I believe, has finished accrual, looking at node-positive patients. I personally believe, and looking at some of that early data, that once a patient is clinically node-positive, I think they are most likely outside of a curable zone. And that's what I treat and quote patients. Now, there are reasons to do a prostatectomy, but not necessarily for cure. Possibly to decrease their tumor burden in a very young man who's going to need multi-agent therapy throughout the next 30 years. But in clinical node-positive patients, positive on PSMA, with an appropriate PSA, I personally don't know that radical prostatectomy is a good option for them. Spencer?
All of my N1 patients who are regionally localized disease are getting ADT, ABI, and radiotherapy at this point in time. And I don't see much of a role until we have any data to say radical prostatectomy really benefits this subgroup of patients, especially as we see more and more that the role of lymphadenectomy is essentially just harming patients as we look at that data.
Just one follow-up. I think the definition of N1 is also changing, right? So as we do more PSMA PET staging, we're starting to catch these sub-centimeter nodes that are avid, and so then that becomes a real, controversy of which bucket do you put those patients in. I will say, as part of, we've done a lot of neoadjuvant trials at DFHCC, including the Proteus trial, which is the big registration trial with apalutamide and ADT, and oftentimes we're including, patients with limited nodal disease in the context of a trial with aggressive systemic therapy.
I'll move things towards the PARP inhibitor data. David, I think we all know that it's getting more and more important to get good genetic testing on our metastatic prostate cancer patients, especially as we think about maybe moving these combinations into the castrate-sensitive setting. How are you testing your patients for HRR mutations, because we have a variety of different tests between circulating tumor DNA tests. We can do somatic testing off of tissue. We can do germline genetic testing. What's your preferred route?
Sure. So I guess a couple of thoughts. First and foremost, germline versus somatic. So we are now, standard of care, offering both to all metastatic patients. We are also offering germline testing to all high-risk and node-positive patients. And I think that any testing is better than no testing. And I think that a lot of the barrier is on getting doctors to offer that in the first place. But certainly germline testing is answering one question, whereas somatic is answering a different question. For somatic testing, I think that where possible, we prefer to do it based off of a tumor sample over liquid. And where possible, a more recent tumor sample as opposed to a more distant one, but with many caveats. So first and foremost, a lot of the driver mutations that are targetable are actually found in the primary as well. And so if you have a relatively good radical prostatectomy specimen or biopsy specimen, it can be very reasonable to test that. Another caveat is that the yield of ctDNA is going to vary dramatically based off of the setting that it's obtained in, right? So a patient who has excellent response to systemic therapy, very low PSA, that's a patient who's not shedding very much ctDNA, and so your yield's going to be quite low. And that's especially important when you're looking not just for mutations like we do in lung cancer world, but actually amplifications and deletions, which is much more common in prostate cancer genomics. And so to actually call that gain or loss becomes very difficult if you have very little to begin with. And that's a situation where tumor can actually be very good. The last reason to sort of prefer tumor above liquid when possible is that there is this issue with CHIP, or clonal hematopoiesis of indeterminate potential, in the blood. And so sometimes if you end up picking up certain alterations in the blood, you actually can't be sure, unless you've done matched sequencing of normal blood cells, white blood cells. You can't be sure that that's actually coming from tumor and not due to a subpopulation of sort of clonal alterations that are present in many of our older patients and not truly targetable, not part of the tumor at all. So I guess the long-winded answer is I have an order of preference here, and it sort of depends on the clinical scenario and what's available to me.
Excellent.
So, can I ask you a question, Dr. Einstein? I think I know what you're going to say, but how do you deal with biochemical recurrence? You discussed it all, but I don't think you gave your opinion.
I think I'm going to hold everybody up from the bar for the next hour or two if I tackle it all. But no, I'm happy to start off on that. It's incredibly difficult. And I think first and foremost, I just want to make sure that my patients know that there's not one right answer, and make sure providers aren't pretending that there's one right answer either. So just discouraging people from instinctively throwing people on systemic therapy for a rising PSA. So I definitely look at the patient and the prognostic factors, right? So what are the patient's competing comorbidities? Many of these patients are older and certainly have other life-limiting things going on. I look at prognostic factors. So we talked about PSA doubling time, but we didn't talk about original Gleason score, time to recurrence, things like that. And so I try to come up with sort of a global estimate of, is this the type of patient who's likely to get into trouble in the next couple of years, for whom it could be quite reasonable to start thinking about intervention. And that's really like the PSA doubling times of less than 3 months, the people who recur within months or a year or two after primary therapy, the people with very high original Gleason scores. I think that we're using a lot of PSMA PET, and we are offering oligomet-directed therapy to some patients, but that too is an entire topic in and of itself of who benefits, should it be done with systemic therapy or without? It's really a wild west at this point. So, I think for the patients for whom I think they're truly at risk, I do use PSMA PET. I do think about MET-directed therapy or local salvage therapies when possible. I think about the use of systemic therapy briefly in combination with that. And then in a patient who doesn't have any oligomets targetable but does have high-risk features, I at least talk about the EMBARK data and sort of say, here's what we know, here's what we don't know. Who are you? Are you the kind of patient who's going to be awake at night thinking about your PSA and want to do anything possible to delay something popping up on a scan? Or are you the kind of guy who says, stay away from me unless you absolutely have to? And I think that in the absence of really high-level data, patient preference is paramount. So I guess that's sort of tackling a little bit of that question, but it clearly gets very, very nuanced.
I think Dr. Glenn Bubley up at Beth Israel Deaconess once told me that non-metastatic castrate-resistant prostate cancer is an iatrogenic disease, for whatever that's worth. And I do treat biochemical recurrence, but I do think about that sometimes quite a bit. I'll pose a question to Dr. Rose here. I think you really highlighted a lot of the excellent uses of potential uses of the urinary tumor DNA for detection of bladder cancer and hopefully reducing the number of cystoscopies for patients. Can you kind of compare and contrast? I know there's a couple commercially available platforms out there right now for detection of bladder cancer. Are those something that you use in clinic?
Oh, yeah, I'm gonna get in trouble for saying this. There's nothing that I currently use in clinic commercially available other than a urine cytology. Okay. That is a urinary marker. Now, we have looked at expanding or creating a clinical trial at Ochsner using a tumor DNA approach to minimize cystoscopies or to decrease the amount of cystoscopies for low and intermediate risk bladder cancer. So that's something that's certainly on our mind. But we do not currently, as standard of care, employ any additional assays from the urine.
Excellent. Thank you. I know nothing about them as a medical oncologist. I had to look up their names.
I'll be honest. I thought we were going to be asking about bladder preserving options, and I thought I'm going to be in a room full of advocates, and they're just be like, "Why are you cutting out bladders?"
Well, okay, so fair question.
Fair question. No, it's no.
Yeah,
why
don't we do more trimodality therapy in the United States?
So I think we're heading in that direction, and we have patient-centric care. I was literally on the way here explaining this to my dad. That there's population data, there's study data, and then there's the man or woman sitting in front of you in clinic that doesn't want to be a part of the 120 people in that study. They want their own choice. And so that's very important to keep in mind on a patient level. I think there are pros and cons to both. I think that what we really truly need to do is be as transparent as possible with the given data and what has been published and what's available. Full disclosure, I am a surgeon. But that doesn't mean that I choose surgery for every single patient. I discuss both options with every single patient. There are some patients that I lean more towards surgery or more towards bladder preservation. The patient that comes in on oxygen in a wheelchair is somebody that I lean more towards observation. Or say, you're gonna love Dr. Halbert.
They do.
They all do. They all do. But I think it's important that when you look at some of the bladder preserving trials, when you really look at the patients who fail who fail XRT and chemotherapy, that total number can be up to about 45% of patients. Okay, and as somebody in fellowship that did a lot of post-XRT cystectomies, that is a very morbid surgery. And so if the patient is still in good enough shape, they have not meted out, they're a candidate for a post-radiation cystectomy. That is a much more troubling surgery to undergo. I think that's something to consider. I think ctDNA and tumor DNA from the urine would be extremely helpful to identify patients who have no cancer left over after XRT or after chemotherapy. Or even patients who I was planning to do a cystectomy on that we gave them chemotherapy up front and they have no tumor left. I think that ctDNA can be a bridge in that to answer that question.
Excellent. Do you think that hydronephrosis, CIS, or multifocal tumor is an absolute contraindication to TMT?
So I don't know in the correct patient that there's an absolute contraindication. The absolute contraindication is where the radiation oncologist says, no, I will not do that. Those are few and far between. Those are important contraindications, but there are other patients that fit into that gap of I expect them to live more than a year and a half, so observation is not appropriate. And I don't think they're going to survive a cystectomy. And again, that's on a patient level, that's a discussion with the family, and that's the art of our trade, right? Is we treat people, we have to sit down and present them this data and make a personalized choice with them and ultimately support them, have their backs.
Excellent.